My name is Majid Constantine. On behalf of my co-author, Dr. Smith, I'm pleased to present our paper, The Role of Statins in the Prevention of Preeclampsia, published in the American Journal of Obstetrics and Gynecology. Preeclampsia is a morbid multisystem hypertensive disorder that complicates 3 to 8% of pregnancies and is a leading cause of short and long-term maternal and neonatal morbidity and mortality. Professional societies in the United States and worldwide currently recommend low-dose aspirin for preeclampsia prevention. Preeclampsia shares pathophysiologic features as well as risk factors with adult cardiovascular disease. Endothelial injury and inflammation underlie both preeclampsia and atherosclerosis. Additionally, preeclampsia has been identified as a risk factor for cardiovascular disease later in life. A diagnosis of preeclampsia more than doubles the risk of future hypertension, ischemic heart disease, stroke, and premature mortality from cardiovascular disease. This is especially significant, and the risk is significantly higher for patients with severe preeclampsia and those who were delivered for preeclampsia prior to 34 weeks. This has led the American Heart Association to include preeclampsia as a risk enhancer for consideration of lipid therapy. Statins are HMG CoA reductase inhibitors and competitively inhibit this rate-limiting enzyme, resulting in decreased downstream production of cholesterol. Decreased intrahepatic cholesterol levels lead to increased expression of LDL receptors and reuptake, and thus lowering of circulating lipids. Statins are differentiated by their potency. First-generation statins, which include lovastatin, pravastatin, and fluvastatin, are the least potent. Second-generation statins include simvastatin and atorvastatin and are currently the most widely used. And the third-generation statins, like rosuvastatins, have the highest potency. Statins are also classified according to their hydrophilicity, with pravastatin and rosuvastatin being hydrophilic, whereas simvastatin, atorvastatin, and fluvastatin being lipophilic. And last, lipophilic statin cross easily into hepatocyte and other cells via passive diffusion, whereas hydrophilic statins such as pravastatin require active transport and thus are more hepatoselective. The principal effects of statin include their ability to decrease cholesterol concentrations and the progression of atherosclerosis. The intensity of LDL reduction by statin is dependent on the dose and the individual drug used. For example, high-intensity therapy, such as with rosuvastatin 20 to 40 mg or atorvastatin 80 mg, leads to greater than 50% reduction in LDL cholesterol concentration, whereas low-intensity therapy such as pravastatin 10 to 20 mg or simvastatin 10 mg leads to less than 30% reduction in LDL cholesterol levels. However, the benefits of statin therapy in cardiovascular disease prevention are not solely explained by their lipid-lowering capabilities. Other factors thought to contribute to the benefits of statin therapy include plaque stabilization, reversal of endothelial dysfunction and endothelial protection, decreased inflammation and thrombogenicity, and decreased oxidative stress. However, is there biological plausibility to use statins to prevent preeclampsia? The pathogenesis of preeclampsia is believed to be a two-stage process, originating early in pregnancy with abnormal cytotrophoblast invasion and remodeling of the spiral arterioles during early placental development. These changes ultimately culminate in an androgenic imbalance with increase in a soluble MFS like tyrosine kinase 1 or SFLT1, as well as soluble endoglin. These two anti-androgenic factors that have been shown to inhibit the effects of the pro-androgenic mediators such as VEGF and placental growth factor. This, coupled with exaggerated inflammation, as shown by increase in the Th1 pro-inflammatory cytokines and decrease in Th2 anti-inflammatory cytokines, as well as increase in oxidative stress. Furthermore, preeclampsia is associated with suppression of the heme oxygenase 1 and carbon monoxide pathways, which have anti-inflammatory, antioxidant, and vasoprotective properties. All of these ultimately lead to widespread maternal endothelial dysfunction, resulting in vasoconstriction and organ ischemia, and eventually the clinical signs and symptoms of preeclampsia. On the other hand, statins have been shown to exert several effects that make them biologically plausible for the prevention of preeclampsia. These include improvement in trophoblast invasion and placental perfusion. Statins are also known or have been demonstrated to promote VEGF and placental growth factor release, reduce SFLT1 and soluble endoglin concentration, upregulate heme oxygenase 1 endothelial and vascular smooth muscle cells, as well as to have anti-inflammatory properties by decreasing the pre-inflammatory cytokine and increasing the anti-inflammatory cytokines. These immunomodulatory and anti-inflammatory effects, coupled with upregulation of endothelial nitric oxide synthase, promoting nitric oxide production in the vasculature, along with other pleiotropic actions on free oxygen radical formation, lipids, and smooth muscle cell proliferation, make statins highly promising candidates for the prevention of preeclampsia. The ability of statins to reverse pathophysiological pathways associated with preeclampsia and to ameliorate its phenotype was evaluated in several preclinical studies using tissue cultures and different rodent models of preeclampsia. These studies overall demonstrated the ability of pravastatin to decrease inflammation, improve endothelial and vascular function, reverse the angiogenic imbalance, and many other pleiotropic actions. These are summarized in this table. Next, we will discuss human studies, and these are divided into preventive and therapeutic trials. First, a pilot double-blind randomized placebo-controlled trial was conducted by the Eunice Kennedy Shriver NICHD Obstetric Field Pharmacology Research Centers Network. This trial randomized women with a history of prior preeclampsia that required delivery before 34 weeks. It was done in subsequent trials, and patients were randomized to either 10 mg or 20 mg of pravastatin orally once daily, or placebo, starting from 12 to 16 weeks until delivery. The primary outcome of these trials was safety of the drug and pharmacokinetic properties. In addition, the trials collected multiple secondary outcomes, maternal and neonatal, as well as maternal and cord blood chemistries. This table summarizes the baseline characteristics, including the rate of aspirin use and the rate of obesity and chronic hypertension, as well as the rate of side effects and adverse events from the two trials. The most common side effects that was experienced by patients exposed to pravastatin were heartburn and musculoskeletal pain, followed by headache. There were no cases of maternal, fetal, or infant death, no cases of rhabdomyolysis or liver injury, and only one patient experienced myopathy, which was defined as weakness without increase in creatinine kinase. There were no difference in the rate of congenital anomalies between the two groups. Next, we present the combined outcomes from these two trials. Maternal and neonatal outcomes were overall more favorable in women randomized to pravastatin compared with placebo, with reduced rates of preeclampsia, preeclampsia with severe features, and indicated preterm delivery before 37 weeks. Recently, another randomized controlled trial by Dobert et al. From the Fetal Medicine Foundation aimed to assess whether pravastatin prevents term preeclampsia in high-risk patients. In their study, the authors screened 38,379 women with singleton pregnancies and randomized 1,120 who screened positive to receive pravastatin 20 mg once daily or placebo, starting from 35 to 37 weeks until delivery or 41 weeks. The primary outcome was delivery with preeclampsia at any time after randomization. There was no difference in the rate of preeclampsia, which occurred in 14.6% in participant in the pravastatin group and in 13.6% in participant in the placebo group. In addition, the study did not show any evidence of interaction between the effect of pravastatin, the estimated risk of preeclampsia, previous pregnancy history, adherence to pravastatin treatment or study drug treatment, as well as aspirin treatment. Moreover, there were no differences in the incidence of secondary maternal or neonatal outcomes, including no difference in the serum concentration of placental growth factors. However, this study was significant as is demonstrated the safety of pravastatin in pregnancy. The rate of maternal, fetal, and neonatal adverse events, including growth restriction, stillbirth, and others, were similar between the two groups. In addition, there were no cases of maternal liver or muscle injury among the 543 patients who received pravastatin. Another trial is currently ongoing in the United States by the Maternal Fetal Medicine Units Network. It plans to randomize women with prior preeclampsia that required delivery before 34 weeks to pravastatin 20 mg or placebo. The primary outcome of the trial is a composite of preeclampsia, maternal death, or fetal loss. The study is also collecting a series of maternal and neonatal secondary outcome, as well as a planned long-term follow-up at 2 and 5 years for children who were born to mothers who participated in this trial. Next, we move on to the treatment studies. The use of pravastatin as a therapeutic agent was evaluated in a prospective study of 21 women with antiphospholipid syndrome and poor pregnancy outcomes. All patients received low-dose aspirin and low molecular weight heparin per local standard of care, and then they were followed closely throughout pregnancy. Patients were assigned to pravastatin 20 mg or placebo when they developed assigned to pravastatin 20 mg or remain on their standard of care when they develop preeclampsia and or growth restriction. Compared with patients in the control group, those who received pravastatin had improved uterine artery Doppler velocimetry, had lower blood pressure, delivered infants with higher birth weight and at the more advanced gestation age. There were also improvement in neonatal outcome, including admission to the neonatal intensive care unit and neonatal survival. Last, the STAMP trial in the United Kingdom randomized women with early onset preeclampsia between 24 to 31, 6 or 7 weeks to either pravastatin 40 mg once daily or placebo. The primary outcome of the trial was the concentration of SFLT1 72 hours post-randomization. This study demonstrated that there was no difference in the primary outcome rates or primary outcome concentrations between patients who received pravastatin and those who received placebo. In addition, there were no difference in other maternal or neonatal outcome, including no difference in prolongation of pregnancy. However, this study confirmed several findings that support the safety of pravastatin use in high-risk pregnancy. Next, what about pravastatin safety? We start with the fetal effects and cholesterol levels. Cholesterol, as known, is essential for fetal development. Although there is physiologic increase in serum lipid concentrations during normal pregnancy, maternal cholesterol supply is of limited importance to the developing fetus in the presence of normal fetal sterol synthesis, as 80% of fetal cholesterol is produced endogenously by the fetus in the placenta. Moreover, several cohorts of patients exposed to statins during pregnancy did not demonstrate increased teratogenicity or other adverse pregnancy outcomes. The largest of these cohorts was an analysis of Medicaid claims from the United States of more than 800,000 pregnant women, including 1,152 women exposed to statins in the first trimester. After controlling for confounders, especially pre-existing diabetes, and after conducting a propensity score matching, there was no increased risk in congenital malformations or any other pattern of anomalies or propensity for select organ systems with the use of statins overall. Moreover, data from the recent human trials in the United States and the UK, in which pravastatin was used for a much longer duration outside the first trimester, support its safety in pregnancy, and as none of these trials have demonstrated any adverse effects on fetal weight. All of these findings were consideration in the recent request by the Food and Drug Administration in the United States to remove the warning regarding use of statins in pregnancy. As for maternal safety, the safety and side effects profile of statins, especially pravastatin, have been studied extensively in the non-obstetric population. In general, statins are considered safe and well tolerated, especially for pravastatin. Pooled data from large randomized controlled trials in non-pregnant patients demonstrated that serious side effects of pravastatin, most notably liver injury and rhabdomyolysis, are extremely rare. On the other hand, myalgias is a common symptom associated with pravastatin use, and its incidence ranges from 0.6 up to 10% in different studies. Last, no significant trend toward more frequent or more severe adverse outcomes was seen in pregnant people in the recent trials. So in conclusion, preeclampsia remains a common hypertensive disorder of pregnancy that is associated with significant maternal and fetal morbidity. Pravastatin has strong biological plausibility, and the data from the pilot trials are reassuring with no identifiable safety signals. This overall favorable risk-benefit analysis justifies continuous research using pravastatin in large clinical trials. Next, I would like to acknowledge funding support. Thank you.